Good afternoon, and thank you for joining us today. I'm Narda Ipakchi, Vice President of Policy at the SCAN Foundation, a nonpartisan public charity that envisions a society where all of us can age well with purpose. And we're here today to drill down on a subset of the older adult population that doesn't typically get enough policy or political attention, even though they have major needs that they struggle to meet. Referred to collectively as the middle market, these are generally low and moderate income older adults that don't have the resources to cover the cost of care or services that they might need or want as they age. And critically, this population is not eligible for Medicaid, and so they're often unable to access or afford the kinds of LTSS services that help people stay in their homes and communities. Within that broader umbrella cohort, we'll be discussing both the forgotten middle population, who have modest incomes and assets but still struggle to afford the care they need, as well as a newer group being dubbed the near dual population, people with even lower income and assets who are very close but not quite financially eligible for Medicaid. These individuals also have similar health and functional needs as those who are fully dually eligible, but being just above that Medicaid eligibility threshold means that they constitute perhaps the most vulnerable and needy of the Medicare population, one for which there are very limited programs available to provide them with the level of help that they need. This is why, we have realized that policymakers have not focused on solutions for these populations. And we are proud to support work in this area that aims to elevate the needs of this population to create more urgency for the policy community to act. And given recent announcements and rhetoric from both presidential candidates about ideas for how to better support long-term care, caregivers, and all Americans, as well as the wave of media attention that those pronouncements have gotten, we feel that now is the perfect time to be reigniting these important conversations. Conversations we hope will finally inform the development of actual policies to support populations so that all of us can age well with purpose. And with that, I'd like to turn it over to my NORC colleague, Dianne Munevar, Vice President of Healthcare Strategy, who will review a summary of the project findings to date.
Hi, everyone. Thank you, Narda. It's great to see so many people have joined today's webinar to hear about our collective efforts with the SCAN Foundation on this groundbreaking research about the middle market and policy solutions to meet the needs of 11.5 million older adults. Before I dive into the research findings, I want to give you a sense of what's to come over the next 50 to 55 minutes. Importantly, it will not just be my voice that you hear for almost an hour of your life on this Friday morning or afternoon, depending on where you're dialing in from. No, we've planned this to be a bit more engaging than that. So I plan to share the research and highlight some of our most interesting and policy relevant findings over the next 20 minutes. And then I'll invite Narda back on this virtual stage and we'll shift to the next phase of the journey in which we'll have a fireside chat. We've invited 3 very special guests to talk with us, mainly to answer our questions and your questions about the policy solutions that we as a collective group have developed during this research engagement. We plan to allow for some real-time Q&A at the end, then we'll wrap up and you can enjoy the rest of your Friday. So without further ado, let's jump in. So why are we here? For the past several years, our team at NORC has been studying issues of the greatest importance to older adults. What we've concluded, along with many, many other researchers and advocates in this space, is that there's a very real imminent crisis that will affect over 60 million older adults and their families and caregivers here in the US. First, there's a housing shortage, which is exacerbated when we think about affordable housing options for older adults. Second, as older adults age, they'll require more healthcare services, and healthcare costs are increasing at exponential rates. Those issues alone, just those 2, are large enough to be considered a crisis. But there's a third, which is a bit of an accelerant: workforce shortages. There just really aren't enough people trained to provide the types of services needed to manage the healthcare needs of 60 million older adults. When we combine these issues, the US healthcare system needs to find innovative solutions that cross multiple sectors and enlist the help of both the public and private sectors. So why are we here today collectively in this Zoom room? Because the middle market faces a policy crisis with no clear solution. A majority of the middle market will be unlikely to afford critical long-term care and housing options, challenging their ability to age with choice and independence. And we are here, we need to solve it, and we want to solve it. So NORC and the SCAN Foundation set out to undertake novel research to inform policy solutions for the middle market with a focus on the lower income end, including near duals. The middle market comprises both the forgotten middle and near duals. The forgotten middle is representative of middle income older adults who may seem stable enough financially, but are really at risk of not being able to pay for supportive housing and care over the course of their lifetimes, should they come to need it. We often use technical language to explain the income thresholds of the middle market, and that seems to keep the issue a bit of an arm's length away. Because really, who really knows what 2 or 8 times the federal poverty line actually means in practical terms? So I think we should be talking about this in real terms, terms that all of us can understand. And I'm going to translate that. The middle market is defined as having income and assets ranging from about $27,000 to a maximum of $103,000 per year. And so I think about that, and I think about recent college graduates, what they make in their first year out of college. And I bet it's more than $27,000. And for some, it might actually be over $103,000. Well, there are 16 million older adults in that segment. And we estimate that 11.5 million of them will be unable to afford senior housing if they suffer even one debilitating event. And that could look like a fall and a hip fracture, or it could mean developing dementia. Now we think about the near duals and their segment of the middle market. They're at the lowest end of the income and assets spectrum. We labeled them as near duals because they look like dual eligibles, people who are eligible for Medicare and Medicaid benefits, and that they have similar health and functional needs, and they're adjacent to full duals as it relates to their income and assets. So in real terms, the near duals are defined as having income ranging from $11,000 a year to $28,000 a year, and up to $26,000 in assets like the value of their home or other depreciating assets. So let's pause for a moment, because if you thought the forgotten middle was in a financially precarious situation with incomes lower than many college graduates, the near duals have annual incomes quite a bit lower, $11,000 per year. That's less than $1,000 per month to cover housing, to cover transportation, food, healthcare, copays, and importantly, near duals are not eligible for the Medicaid safety net. These individuals are literally one fall, one hospitalization away from spending down to poverty within 1 or 2 years. Since 2019, NORC and the SCAN Foundation have defined and published volumes of research about the forgotten middle. And if you're interested in learning more, I urge you to look at the NORC and SCAN websites, which are chock full of our research briefs and chart facts. What I want to focus on today is our most recent forgotten middle and near duals research. Our most recent forgotten middle research examined the housing and healthcare future for middle income seniors, projecting their financial resources and healthcare needs in 2033. And importantly, our updated research looks at the diversifying profile of the middle income and how the crises I've articulated above is actually worse for Black, Hispanic, and rural populations. The results are grim, but we all believe that the problems are solvable. Updating our research to project, updating the research on the evolving demographics of the older adult population in 2023, we found that not only will the forgotten middle nearly double in size, but there are 2 additional phenomena coming on. One is no getting any younger. Just like with the past and current generations of middle income seniors, this group will have increasing health needs. Over 1/2 will have 3+ or more chronic conditions. Over 50% will likely have a mobility limitation, and almost 1/3 will have cognitive impairments, which makes it very difficult to live independently. A second phenomenon is that while not everyone will require housing supports and extensive healthcare services, many will. And nearly 3/4 of middle income seniors are projected to not have the financial resources to pay for private assisted living without selling their homes. So as I mentioned above, our research this year took our middle income research and added a very necessary, very relevant perspective. One area of research was on historically marginalized and minoritized groups within the forgotten middle. NORC and the SCAN Foundation prioritized this research area because of the gap in the literature and policy space around disparities faced by Black and Hispanic older adults. More data is needed to inform culturally competent and equitable policymaking. What we found was that among those 11.5 million individuals in the middle market who will not be able to afford senior housing, Black and Hispanic older adults in the forgotten middle are at a particularly acute disadvantage. Home ownership rates among Black older adults is projected to fall from 82% to 69% between 2020 and 2035. And the situation is even more perilous for the older cohort of seniors age 75 to 84 at 65%. Shrinking home ownership rates will preclude many Black older adults from aging in place or leveraging their home to pay for future care needs. Another potential way for older adults to pay for needed housing and healthcare is to use other liquid or appreciating assets like IRAs and stocks. But as you see, this isn't a fruitful avenue either. Black and Hispanic older adults tend to hold fewer appreciating assets like stocks, IRA accounts, and other real estate. And compared to their white counterparts, they often lack assets that grow in value over time that could provide additional resources for their aging needs. Instead, we see that on average, Black and Hispanic older adults have higher proportions of depreciating assets, like a car or savings account, neither of which will be particularly helpful in paying for the rising costs of long-term housing support and healthcare costs. When we look at the full picture of financial resources and we segment financial resources into quartiles, and then we further stratify by race ethnicity, we see that overall, older adults of color in the forgotten middle are clustered at the poorest end of the financial spectrum. They tend to have the lowest income and assets to support themselves in older age. So what does this research mean for the forgotten middle for policy? Well, in the US, we're in dire need of policy modernization as it relates to older adults. A bold, need-based policy solution is required to provide older adults with the services and supports they need to age in their setting of choice. A new policy cannot be written and implemented absent a recognition and deliberate approach to understand the needs of Black and Brown and Hispanic communities that increasingly make up the forgotten middle. So policies need to be both culturally competent and focused on equity. Transitioning now to the near duals, we set out to do this research because we knew that after years of research on the forgotten middle, we knew that the forgotten middle is actually relatively broad in terms of financial resources and healthcare needs. We recognize the need to also focus an important subset of the middle market who are at the cusp or on the bubble of full Medicaid eligibility and who are otherwise unaccounted for in much of the literature and policymaking debates. The near duals are the most financially vulnerable subset of the middle market. And as I mentioned above, their income levels range from $11,000 to $28,000 per year. One of the most important findings to note when we did our research about the near duals is really just how similar they are to full duals. So again, those that are eligible for both Medicare and Medicaid benefits when it comes to their need for long-term supports and services. In both groups, a majority of individuals have mobility limitations and 4 or more chronic conditions. And close to half of near duals live alone, potentially experiencing social isolation and loneliness, and in rural, medically underserved areas, which really further heightens the challenges in accessing healthcare services. While full duals with similar functional profiles are eligible and can enroll in Medicaid long-term services and supports, which meet their health and functional needs, near duals are not eligible for Medicaid. They're not eligible for those services and programs that many of them need so dearly. Our near duals analysis also included a deep dive on healthcare coverage, looking at the various Medicare programs or Medicare Advantage plans and benefits available to this population. One such benefit that would be appropriate and available to near duals is the use of the Medicare savings programs. What's curious is that the overall low utilization of financial assistance available with these programs. Despite this group's low financial resources, only 18% of near duals are enrolled in MSP, indicating there's real potential lack of access to a program for which many are eligible. And here in this moment, there lies another policy opportunity. When we set about this research journey about the near duals, a lot of us thought and assumed that a very likely outcome of being a near dual is that they would very likely transition to Medicaid and then become eligible for a wide range of long-term services and supports. So while one might assume that a large number of near-duals transition, we found that the proportion of transitioners is actually remarkably low. Over the course of a 4-year retrospective study from 2017 through 2020, we found that only 6% of near-duals became full duals. What this means is that near-duals tend to remain in that highly precarious situation with relatively low financial resources, higher needs, and limited access to care. So what does this research mean for the near-duals? Near-duals live at the intersection of financial insecurity and complex health and functional needs, with many similarities to full duals. Despite these similarities, though, many near-duals are unable to access Medicaid long-term care services. Instead, these beneficiaries or these enrollees likely rely on unpaid family caregivers or go without needed services, which is likely has a very negative effect on their physical, mental, and emotional health. Given that near-duals face similar financial and health challenges as many full duals, proposed policies should provide greater access to the current long-term care supports available to the full duals. And moreover, a policy solution that offers select care services broadly to all older adults with specific needs would provide meaningful support and protections to the near-duals, to the forgotten middle, and to others in Medicare. What we found most compelling about our work with the SCAN Foundation over the past year to 18 months is the commitment to talking about the impact, or the so what. And so importantly, what we can do to begin solving the issues is going beyond examining and redefining the problems, but really coming and proposing new, bold ideas to fix the crisis. This research portfolio was scoped with the clear understanding that the research was performed in service of proposing policy solutions that were informed by rigorous research. There is a clear call to action here. These data substantiate the challenges facing the middle market, which require policy action today. Notably, these policy solutions were developed in conjunction with a group of 20 interdisciplinary leaders from across the housing, healthcare, and aging sectors, each with different perspectives, sometimes opposing perspectives, and we did that intentionally. We really wanted to dig in. So the policy solutions we drafted are working drafts and are aimed at facilitating a more affordable, equitable, and accessible aging environment for middle-income seniors. The first policy solution is to develop a pathway for a new benefit under Medicare for home and community-based services. When we thought through what this benefit looked like and we really pressure tested it with our policy group, we recognized that it requires 4 things. 1, a universal approach to coverage. 2, needs-based, not means-tested. And I'm going to say that one again. Needs-based, not means-tested. 3, self-directed benefit that could be used on a menu of home and community-based services. And 4, a policy that could leverage differential cost sharing. The second policy option is to expand and harmonize Medicaid eligibility requirements. And there we also have 4 criteria. 1, this policy solution should incentivize states to increase the age, blind, disabled Medicaid financial eligibility to 138% of FPL. 2, it could reset the aged, blind, disabled thresholds, provide enhanced FMAP and other potential options. 3, facilitate greater MSP or Medicare Savings Program enrollment. And 4, technical assistance and guidance requiring the MA plans to provide MSP education and support to their members. The third policy option is to expand the scope and eligibility of home modification programs. Increase funding to well-established programs through federal agencies like HUD, the USDA, and evidence-based regional programs like Capable. 2, to update guidelines to expand eligible populations to cover new near-duals and the forgotten middle. And 3, to broaden the scope of services to provide modifications that go beyond accessibility. And the fourth policy option is to increase flexible national funding for community-based programs. We need to increase funding to existing programs like the Aging Network, the Community Development Block Grants, programs that leverage existing partnerships and infrastructure and the understanding of the unique and variable community needs that provide care services to the older adults who aim to age in home and community. So with that, I'm going to take this moment and turn it back to Narda, who's going to give you some introductory remarks ahead of our fireside chat.
Thank you so much, Dianne. Really appreciate that presentation and just noting that this research really is critical for informing policy ideation and driving consensus. I think the recommendations and findings that you shared today really are part of a broader recognition that many aging Americans cannot afford the care and services they need or want, and builds on many years of research that both we and others in the field have been working on to better support this very vulnerable group of older adults. But I think everyone on this call knows that, of course, research alone doesn't result in policy change. I think my favorite header in your presentation, Dianne, was the slide that said, policy change is needed now. We know that the private and public sectors really have to come together urgently to address those gaps that were elevated today. And so we hope that this research can be the start of a conversation and can help inform and equip those that really are in a position to advance policy, those, advocates, industry leaders, policymakers, to work together to move the needle on reforms in this area. As mentioned at the top of the call, I think what's really relevant and timely right now is that these issues are getting attention as a result of recent presidential candidate announcements around this very issue. And so I'm looking forward to this dialogue continuing and the fact that we are able to have such great people like the folks on this project to advise the policy solutions going forward.
Narda, I love how you framed that, particularly recognizing the need for solutions that pull together the private and public sector, and of course, noting how well our research aligned with Vice President Harris's news. So given how cognizant we are of the current political landscape, our work focuses on 4 different policy solutions that vary in scope and impact. With policymakers recognizing the current crisis facing older adults, and really all of us, it's crystal clear that now is the time to push for further research into fleshing out actionable policies and doing some math on the expected costs and impacts, the benefits of these solutions. As we move into the second half of this webinar, I want to not only introduce our esteemed panel of experts, but I want to thank each of them for being part of our advisory group of experts when our research pivoted from data analyses and brainstorming solutions that aligned with the evidence that we were producing on the health and housing needs of the middle market. Our advisory group, which included Sarah, Amber, and Jennifer, who I'll introduce momentarily, provided such rich guidance on the development and refinement of these big, bold solutions for the middle market and beyond. And of course, thank you for your time today, the audience. You are going to love this upcoming part. On our panel today, I want to introduce our experts, and then we will move into question and answer. So first we have Amber Christ, Managing Director, Health Advocacy at Justice and Aging. We also have Jennifer Molinsky, Director of the Housing and Aging Society Program at the Joint Center for Housing Studies at Harvard University. And of course, Sarah Steenhausen, Deputy Director of Policy, Research, and Equity at California Department of Aging. So with that, I get to go first. My first question is for Sarah. Sarah, you've mentioned to us that California, through its Master Plan for Aging, is engaging in research to identify a range of policy options to address the financing crisis impacting the missing middle, including how Medicare could play a role. Can you today talk about this initiative and what policymakers may want to consider in developing a national Medicare benefit?
Well, yes, thank you so much, Dianne and Narda, and a huge thank you to NORC and the SCAN Foundation. It's so exciting when, working in the policy arena to see the intersection of research and policy. And, I'm just very hopeful that we might be at a place where there could be a window of opportunity. So I'm really excited to talk to you about the work that we're doing in California in alignment with the Master Plan for Aging. Key to the Master Plan for Aging has been how we can address this LTSS affordability crisis, particularly focusing, as you noted, on the missing middle population. Recognizing that there really is not one size fits all approach that will be the silver bullet solution. So, like the research that you noted, in California, we also have an increased aging population, which is increasingly diverse. California is, moving upon being a majority minority population. And that's really important for us to consider the cultural appropriateness of services and delivery. We also have tremendous affordability challenges and increase of older adults entering poverty, housing challenges, and growing older adult homelessness. So we really need to put the pedal to the metal and figure out how to solve this issue. So as part of that, we're really fortunate to have an initiative that we've been able to advance in partnership with UMass LTSS Center, led by Dr. Mark Cohen, in partnership with Community Catalyst, Urban Institute, ATI Advisory, NORC, Milliman Actuaries, and the Harvard University Joint Center on Housing Studies with Jennifer Molinsky as well. And as part of this broad effort, we're looking at not only the population needs today, but trending it out into the future. We're also thinking about program and policy options at the state level, but what that looks like for both Medi-Cal in California, Medicaid, and potential Medicare options. And then finally, we are really focusing in on what consumers think and doing some evaluation survey work in partnership with NORC, as well as consumer focus groups across the state. And then all of this together will present a final report to the legislature in June of 2026. But what I want to talk to you about for the next few minutes is the work that we're super excited about right now that's part of this effort that we're leading with UMass and Mark, as well as ATI Advisory and Milliman Actuaries. And this is focused on looking at how we can develop a case for Medicare to play a role in home and community-based services. So ATI has done a lot of research looking at California's Medicare population and really what target population you could make the evidence for that actually investing in home and community-based services for those with high functional needs would actually be a cost savings to Medicare and potentially, as we know, actually helping people stay at home and avoid having to fall into poverty. So I want to just elevate some of the early significant findings and what we're doing next about this. Through ATI's analysis, they have found that, those Medicare enrollees with functional needs account for approximately 20% of California's Medicare enrollees. And that represents 50% of all Medicare spending for those Medicare enrollees in California, as well as 67% of ER hospitalization and post-acute spending. This statistic right here is so significant because what it suggests is that functional need drives acute care spending. And if we're able to show that investing into specified home and community-based services for a defined population, we can actually hopefully prove that this could save money and avoid avoidable expenditures in the Medicare program. So what we're doing right now is we are putting together all of this work as a body of work, and we're doing the actuarial analysis of a targeted benefit that really looks at home and community-based services and spelling out what those services would be. And I really want to emphasize, I know some of the federal discussion has been on home care benefit, but we're really trying to emphasize home and community-based services because a lot of people, yes, we need to have options for people to be able to stay in their homes, but we want to also ensure that people can remain part of the community as they, depending on their preferences. So that includes community-based options such as adult daycare and others. It also means having to look at transportation options and other needs as people try to access services at home and in the community. So we have developed this model that looks at specified home and community-based services, as well as care coordination, and also leveraging models such as Capable for certain defined population. And we are going to be presenting these findings along with the actuarial analysis in the next few months, hopefully, and then entertaining a discussion with our federal partners. We are hoping, if it's possible, to kind of give all this data to the Federal Center for Medicare and Medicaid Innovation. What's really critical in any kind of Medicare demonstration under CMMI is that you can show both cost savings and improved opportunity for care delivery. So with all of that, it's just to say this is a teaser for the next few months. Our interest is, this is bigger than California. So yes, we would love to be able to get to the point where we can pilot a demonstration like this. But given the timing of this federal conversation, we're really hoping that this work can be valuable for the whole national conversation. And hey, if our federal partners want to take the data and use it for their own purposes, that's great as well. So we look forward to releasing that as soon as it's available. So thank you.
Thanks, Sarah. I'm gonna probe you on one piece. So we envisioned this benefit as providing a menu of HCBS services contingent on that need-based criteria. My question for you is, why focus on HCBS? And I think you've already answered some of that, but I think the second part of that is, what else would need to be in place to ensure sufficient infrastructure?
Mm-hmm. So, well, if this is just Sarah talking and you're not, I don't know, are you saying like LTSS is much bigger than just HCBS is what I hear you saying? And so, yes, it's a great point that it is our collective interest to try and find ways for people to stay at home and in the community according to their needs and preferences. But we also know that not everybody, that's not an option for everyone. So this issue of how you finance assisted living, we know that Medicaid plays a limited role in some 1915C waiver services. So it's a great question and a great need. We're not pursuing that as part of this effort. Just, I think what I would say, it's primarily because of cost, and it is such a significant cost driver. And to that extent, again, I feel like we, as in this part of this national dialogue, we know that if people can't stay in their home and then they end up having to move into other settings, they end up exhausting all their resources and going on to Medicaid. So I would hope that we can continue this policy discussion at the federal level and push the envelope for a case for, again, a Medicare benefit that is not only home and community-based services, but also for assisted living. That's just me speaking. But that's not what our demo is focused on right now.
Thanks, Sarah. And just one other question, and I would open this to you or anyone else on the panel, which is, I think oftentimes in conversations around a new Medicare benefit and a new Medicare benefit such as this one, the whole sort of Medicare solvency discussion comes back on the table. And I'm sure too that as you are having discussions with CMMI, obviously part of their charge is to be able to demonstrate, budget neutrality or net savings. And so I'm just curious, from your perspective, what some of the most important considerations are for policymakers who are having that sort of solvency piece looming in their minds as this conversation continues.
That's such an important question. And I will say that because CMMI has very high standards, that you can't just show budget neutrality, you actually have to demonstrate savings. So we're trying to make that case right now. And that's why we're having to be so targeted in terms of the population and of how the benefit's structured. If you can't show savings, then it brings up that whole issue of the Medicare solvency. So that's another reason we're super excited about this work, is because we can actually hopefully demonstrate the savings so that you would avoid that conversation on the solvency of Medicare, which is a super important consideration.
Thank you so much. I'd like to turn next to Amber. We obviously had, one of the pieces of this was a significant amount of research around the near duals. And generally the conversation around that population has been whether or not there's a reason to act because there's sort of an assumption that many of those folks will eventually be on the Medicaid program, where the Medicaid program will offer those long-term services and supports. We obviously saw from the research today, which I think reinforced research that MedPAC and others have done in decades past, that a very limited number of people actually transition to full dual from near dual.
Mhm.
And so one of the policy recommendations that was included in this project was around increasing financial eligibility for Medicaid up to 138% FPL, which we know that some states have already done, but many others have not. How do you think that that could impact folks if we were to able to raise that financial eligibility limit?
Yeah, thanks, Narda. And thanks for having me here today, and to NORC and the SCAN Foundation and my fellow panelists. I'm really excited to be here. So Justice and Aging focuses on securing access to health and long-term care for low-income older adults. And I think what we've established here with this data is that near duals are low income. And not only are they low income, but they pretty much are so much similar to people who are fully eligible for Medicaid benefits today, but for the income limits. And that really speaks to how exceedingly low the income limits are in Medicaid aged and disabled programs. Just to put a fine point on it, today the income limits in aged and disabled programs across the country are at the low end, about 72% of federal poverty level, up to like average 100% of FPL. Like you said, Narda, some states have gone beyond that, but that's the typical range. And then put that in real dollars, that's $940 a month to at the high end about $1,200 a month. And then there's the asset limit, which is $2,000, which is also incredibly low. And I think I noticed that Mark Cohen is on today. And I just want to give a shout out to a study that he did that shows that it's really income limits that keep people off of programs. The low income people with this amount of income aren't able to accumulate a lot of resources. And so that's why we're not seeing the near duals transition into full dual status. It's their income keeping them off of the program, not their assets. There's no spending down anything. They have a set form of income, and it is slightly above the current Medicaid eligibility thresholds. And those low financial eligibility thresholds are problems across the states, but that problem's particularly highlighted in states that have expanded under the Affordable Care Act, their Medicaid programs up to 138% of the FPL. And that's 41 states today. So if you live in one of those 48 states and you're on Medicaid, expanded Medicaid, if you turn 65 or become eligible for Medicare, you're going to lose eligibility for expansion Medicaid and have to meet those stricter eligibility limits under the aged and disabled programs. So your income and assets haven't changed. Your needs have probably increased. So the only thing that's changing is that you've turned 65 or you've obtained Medicare coverage, but now you have to meet that stricter eligibility standard. So it just highlights that gap. So I think there's two things that we can do. I think it's really also important to note that a lot of states have a separate Medicaid eligibility pathway that allows states to go or allows people to obtain Medicaid eligibility at higher limits, up to 220% of FPL. But you have to have an institutional level of care need. So if you have a lower level of care need, you have to meet the aged and disabled program limit. And if you have an institutional level of care need, you can have higher income. But this policy effectively limits or restricts assistance to those only when they reach the highest level of need. And that contradicts kind of the goal of providing care when you need it, to preventing or delaying worsening health outcomes, enhancing quality of life. So I think that we could raise aged and disabled programs and bring parity between expansion Medicaid and aged and disabled programs, and we would help address the cliff. We would bring in some of the near duals into Medicaid coverage, but not all. And we would help address disparities based on race and other demographic factors. But a really comprehensive solution would be actually to raise the income limit in aged and disabled programs up to that 220% mark. We'd capture the full range of the near-duals population, and allow people to get the care they need when they need it, rather than just when they're at an institutional level of care.
Had to find the unmute button, believe it or not. Amber, we acknowledge that there's a lot of individuals who are currently eligible for full and partial Medicaid benefits, and I walked through a little bit of that. I have one slide on that here, but as you know, there's probably a 60-page slide deck on that on the website. They don't access the services, and it could be due to administrative complexities and burdens. Can you share a little bit about what you think could be done to facilitate greater access to those services and enrollment in MSP in particular?
Yeah, and maybe I'll back up and just talk about what Medicare savings programs are to start with. So these are programs that help, they're Medicaid programs that help pay for Medicare out-of-pocket costs, including premiums and cost sharing, and that cost sharing can include copays and coinsurance and deductibles. A little confusing because you've got a Medicaid program paying for Medicare out-of-pocket cost. And many near-duals would qualify for Medicare savings programs. And the impact of that financial assistance is really significant. Just alone, the Medicare Part B premium in 2024 is $175 a month. So that's about $2,100 a year. For many near-duals, this is more than 10% of their annual income. So being enrolled in a Medicare savings program can bring a lot of financial assistance to someone and increase their financial security and free up that dollars for other healthcare needs or housing needs. But Dianne, as you noted, there are a lot of people who are eligible, but not currently enrolled. And there's a wide range of reasons for that, from, like you said, administrative complexity and enrollment, not knowing about the problems. I want to highlight some things that are happening that I think is going to help, and then flag a couple of opportunities that I think could go further. So there were new federal rules passed, put into place in it was last October, so it's been about a year, but have kind of gone into effect now, that will require states to automatically enroll people into Medicare savings programs. So one of these rules has already taken effect. It took effect at the beginning of this month, and that is automatically enrolling SSI recipients into a Medicare savings program, specifically the QMB, or Qualified Medicare Beneficiary Program. So states are supposed to be automatically enrolling those individuals. The other rule is to use Social Security data about people who receive the low income subsidy for help with their Medicare Part D premiums through the Social Security Administration, to take that data and transfer it to the states, really wonky term called leads data, and send that to the states. And then the states can use that to automatically enroll people into the Medicare savings programs. That rule has been in place for a long time, but states are going to have to come into compliance in 2026. Obviously, we would encourage states to take action sooner. There's nothing stopping states from doing that now. We heard from advocates in Illinois that they've taken that action and they've seen increased enrollment. Keeping in mind that these are people who are already eligible. They just aren't enrolled. And CMS has anticipated with these rule changes that about 500,000 people that are eligible but not enrolled will get enrolled through these rule changes. So big changes there. I think another change that states could take is eliminating the asset limits in the Medicare savings programs. Right now, the federal limit is at $9,400. Again, people with low income aren't able to accumulate a lot in assets, especially the type of countable assets we're talking about at that limit. And so eliminating that asset limit just allows already eligible people to more easily enroll. It removes an administrative barrier. And in fact, in the 12 states that have done that, they haven't seen an increase in newly eligible people. They just see more people easily able to enroll who are already eligible. And they've gotten savings from removing that administrative barrier because their staff is no longer having to prove assets for those programs, and that results in savings. And really, there's states across the board who have done that, from Alabama to Louisiana to Mexico to California to Connecticut. So we really have a wide range of states that have eliminated those asset limits. So I encourage states as a way of increasing and facilitating enrollment in Medicare savings programs to do that. And then finally, there's outreach. a lot of the near duals aren't touching the Medicaid program because they're not technically, quote, eligible for Medicaid, but this is a Medicaid program. And so thinking about using our SHIPs, our AAAs, our area agencies on aging, benefit checkups to make sure that people are getting connected and know about these Medicare savings programs. And I'm just going to say that funding for outreach to help people enroll in these programs is expiring at the end of this year. So it's really important that Congress were to renew that funding and even increase it, because it is so incredibly important that people are enrolled in these Medicare savings programs.
Thank you, Amber. I want to turn now to a question for Jennifer. So Jennifer, our final policy solutions pertain to the need for greater funding and flexibilities for older adults, housing initiatives, and community-based programs. There are already several well-known housing initiatives that exist at both that federal, state, and local levels. But what are the needs that are still not being met by current programs, and what can be done to fill those needs for the middle market in particular?
Well, first, thank you for having me today. I'm really grateful and happy to be part of this conversation. And I want to say first, too, that I appreciate very much that your recommendations extend to housing and community-based services. I think as a housing person, I always come to these conversations trying to emphasize that people's homes are not simply boxes in which care occurs, that we've got their first and foremost homes with all that connotes. And then we think about affordability, and a third of our older adults being cost burdened. Housing debt, which is increasing. We've got over 30% of our owners 80 and over have mortgages now. Less than 4% of our housing stock has basic accessibility features. And then on top of that, of course, there are wide disparities in people's housing experiences in quality, accessibility, and all of that. And as Dianne mentioned, I think many people are not stably housed, and they're one crisis away from losing their housing. So I think from a healthcare perspective, it's really critical that these complexities and these disparities are understood and taken into account. So now to get to your question, yes, there are a number of important programs that support older adults with low incomes, like housing vouchers and public housing. Critically, those are not entitlements. And right now we're only serving 36% of older adults who are actually eligible for those programs. So of those not served, we've got 2.2 million older renters with very low incomes who qualify as having worst case housing needs, meaning they are housing cost burdened at 50% of their income. They're living in severely substandard housing or both. Of course, we have tax credits. We have other programs that can help support the development and operation of affordable housing for older adults, but there's just simply not enough to meet the need. And when you think about the growth of that population, we're looking at households in their 80s doubling before 2040. That's really significant. I think there are fewer supports for middle-income older adults, despite the fact that very few can afford both their housing and the care they need to remain in their homes. We've started to refer to this as the dual burden of housing and care. And our research really mirrors what the stat that you said, Dianne. We find that 3/4 of single people and couples 75 or over in major metro areas cannot afford one daily care visit at home out of their income on top of their housing. And so for us, it's really about taking the cost of the care and the cost of the housing together, and then realizing that so few people can afford that it's just really vast on top of just basic costs of living, basic costs of housing. So I would say we need more housing options. I am really, I guess, a proponent of aging in the right place. So for some people, as Sarah said, that is not the current house, but keeping people in their communities and connected to the services and the social aspects that they have. So that's where I think there's a big role for state and local governments and thinking about removing barriers to more condos, more apartments in the central parts of our towns and even our suburbs, creating some efficiencies of scale in terms of the proximity that people have to services. And then I think, considering the housing stock we have, one thing I really love about the proposal you make is that home modification is such a need. And we even see home repair being a huge need, right? And older adults with limited incomes or their wealth is tied up in their house are often not making those repairs that maintain their home equity. But one thing I love about your proposal is the acknowledgement that sometimes you don't want to wait for a disability to modify your house. You want to modify your house so you don't fall inside the house and have a disability. And so that's a really important piece, I think. I guess the last thing I would say is that we can do better at coordinating the housing and the service, the application. So Dianne, you were just talking about why people may not sign up for benefits for which they're eligible. And Amber, you responded to that as well. When you add in housing and you add in the gajillions of paperwork that you have to and all the eligibility requirements, there are big gaps between support for housing and support for the services and supports you need to stay in the house. And so just better linking those and coordinating those would go a long way.
Thanks, Jennifer. And at the top of your response, you mentioned coming into a lot of the conversations with healthcare folks and having to remind them that a house is not just a box in which people live. And I think probably the same can be true vice versa in terms of when healthcare people are in the housing setting. And I think one of the things as this sort of intersection between health and housing has become more apparent, that one of the challenges to any movement has been the siloing of these different policy areas, both at the state and federal level. They're handled by different federal agencies. There are different committees within Congress that have jurisdiction over these issues. So I'm just curious from your perspective, like, what can be done to better to some increase some of that coordination and collaboration across health and housing stakeholders so that we're not having to remind folks each time and start this conversation from a new point.
That's a great question. I feel like there's this frontier between health and housing that exists in policy, and it also exists in research, right? It exists with data. I think we could do better, collect better data that is more aligned, that helps us understand the outcomes for health of housing-based interventions. That can be really hard to do right now. So I think there are a lot of possibilities, sort of forums like this. The more we are getting into each other's audiences, the more we're understanding the acronyms and actually speaking the same language. I think that shouldn't be underestimated, right? But I think that there's a lot that we can think about in terms of making this real, making people's housing situations real. One way I just do it is to think, if you're a household, if it's you or your parents or a relative, you have to think of this stuff together. You have to think of how I'm going to pay for the roof over my head and how I'm going to pay for supports and services to stay in the home. That's how real people have to deal with this. And so just sort of taking that mindset up to government, which is, of course, obviously separated and siloed for obvious and important reasons sometimes. But to sort of like draw on that, I think, as inspiration for really trying to work together.
That's great. I do want to be mindful of time. This has been such an engaging and dynamic that the past 54 minutes have gone like that. I think we have one more question that we'd like to pose to you all, and kind of get your input, from each of your perspectives. Before I pass it off to Narda to do that, I do want to let the audience know that we have been reading all of your questions. We've been trying to answer them throughout when we've asked questions and included them in the probes. We have more questions than time, as is typical. So what we will do is review them, and if we can point you in the right direction or get your question solved on the back end, we will do that. So your question will be answered. It just may not happen in the next 6 minutes. So with that, let me pass it back to Narda.
Ooh, last question. Well, I think our advisory committee, folks from our advisory committee know well that in the conversations that we had in those expert convenings, we did talk a lot about the balance between putting forth policy proposals that appeared to have more sort of political buy-in or could appear more politically palatable versus the recognition that we do need something bigger and bolder. And so just curious if if you all could share from your perspectives and from the organizations in which you sit, do you see any of these proposals potentially garnering support from both sides of the aisle and being able to move forward? And what do we need to do to make that happen?
Well, I'm happy to start, but I think that one thing that strikes me is that this really is an issue that impacts everyone. I think that this is something that all families are struggling with. So presenting it in a way that shows that they're actually we're all paying for this at one point or another. So if we can demonstrate that you can provide support for these services through something like Medicare and actually show cost savings for it and demonstrate that the cost still hits the consumer and families down the road if we don't provide that coverage. I think that's the real selling point. But I look forward to hearing from the other panelists as well and your thoughts on that.
I can build off of what Sarah said. I've been reading Medicare and Medicaid at 50, so it's now 10 years old. But there's a line in that book about the political and policy logic have never been in sync when it comes to long-term care. So policy has always been trying to create solutions for long-term care, but there's never been the political will. But to Sarah's point, I feel like that gap is narrowing because we all are experiencing it every day. It's almost impossible to ignore. And that gives me like hope for big, bold policy opportunities. But I do think it is these incremental changes that demonstrate that we can get things done now, but build the evidence for those bigger policy changes. And just thinking about some of the income increases we've seen in states from eliminating the asset limits in the Medicare savings programs and that making eligibility easier. You could see at some point like the federal law changing and saying, okay, no more asset limits, right? There's sort of a tipping point that we can get to in which there's such great evidence that this is good policy that that feels really to move the needle to me. But I think it's a both and strategy. I think we pursue the bold strategies and continue to move incrementally and that they feed into each other. And continue to uplift the need over and over and over again. And I think our work in the policies allows us to tell those stories of the people who are impacted, either positively by new policy changes or negatively because we haven't acted.
I would concur with all of what's been said. I mean, I love the idea of bold reform. I think we need a bold conversation to go with it. I really think we need to. I think there's a way that we think that what happens in people's retirements or what happens in your home is a personal, private thing that is your business. And if you can't afford $48,000 a year for the median cost of a home health aide, that's somehow on you, right? It's not a personal failure. This is a societal issue and it has repercussions for all of us. And I think we kind of, as we sort of want to have people have choice and want to stay in the community and want to stay in their homes, also recognize that that doesn't mean this becomes a private issue, that we're pushing things into families, that we're, that we really have a public stake in addressing these issues. And that would be the kind of conversation that I would hope to see. And I think it's happening, but more of it.
Well, great. Well, we have a minute left. I want to, thank you all. Thank the panelists. Thank Narda, the SCAN Foundation, for giving us this space to do this work. Thank the attendees for joining us on a Friday afternoon or Friday morning, if you're calling from California. And I also specifically want to tell the SCAN Foundation how thankful we are, because we could have done this work and proposed only incremental. And many months ago, we talked about whether should we do incremental or bold? And I'm just so happy that the SCAN Foundation said, no, let's do bold. Let's go big. We have this moment in time. And so I've been very inspired. Our team's been very inspired, and just want to tell you how thankful we are for that opportunity. With that said, yay. Well, with that said, thank you, everyone. Have a wonderful rest of your Friday and weekend. Bye-bye, all.